such a privilege and such a blessing again. Dr. Khawaja is a board-certified psychiatrist and sleep medicine physician. He completed medical school from King Edward Medical College in Lahore, Pakistan. After he finished medical school, he came to the U.S. and completed a residency in psychiatry at New York Medical College in Baha'u'llah, where he served as chief resident in his 4th year. Dr. Khawaja was a recipient of the Award for Academic Excellence during his residency, and he scored in the 97th percentile in the service exam. Brilliant guy. Yeah, I'm just blown away by your contribution. He moved to Minnesota where he worked at the VA Medical Center as the director of the Partial Hospital Program. He got interested in the field of sleep medicine and went on to complete a fellowship in sleep medicine at the Mayo Clinic in Rochester. Was that Minnesota? Yes. He was awarded the Bush Medical Fellowship from the Bush Foundation in Minnesota, and then went back to the VA Minneapolis and expanded their sleep program. In 2013, he was appointed as the medical director for the Minnesota Regional Sleep Disorder Center at Hennepin County Medical Center, which is one of the oldest academic sleep programs in the country. He worked there with Dr. Carlos Schnegg, who has discovered several sleep disorders, including REM behavior disorder. Dr. Khawaja has close to 100 publications, including peer-reviewed papers and reviewed papers, book chapters, and editorials. He's been a co-director of a full-day course, Sleep Medicine for Psychiatrists, a review at the American Psychiatric Association annual meeting for 5 years. He runs the Sleep Center at the VA Medical Center and is the CEO of MD True Care PA, which is a practice providing psychiatry, endocrinology, and sleep medicine services in Grapevine, Texas. He has just completed a book, Sleep and Comorbid Psychiatric Disorders, a case book by Springer, which will be published early next year. So please help me welcome Dr. Khawaja.
Thank you. Okay, so sleep disorders, how many of you have patients who have sleep issues in your practice? So as mental health therapists, psychiatrists, psychologists, all of us have patients. And when we look at PTSD, for example, it's even worse. So if you look at a lot of studies, 70 to 87%, according to one study, patients with PTSD had sleep disruption. So that's a huge number. Now, if you look at sleep complaints at 1 month can predict, but not at 1 week, post-trauma are a significant predictor of PTSD at 12 months, meaning that somebody is having sleep trouble and they have gone through a trauma, and after a month they still have those sleep problems, they're going to have very high likelihood of developing post-traumatic stress disorder. So that's huge. Now, we have to still figure out whether we could manage or control or treat those sleep disorders or disturbances and whether it would prevent PTSD or not. So we know that treatment of sleep disorders, if you treat sleep disorders in patients who have mental health issues and in PTSD, it helps. The outcomes are much better. And in my career, I was a psychiatrist for several years before I went into training. So I didn't go into fellowship in sleep medicine right after my residency. So I was practicing for several years, and I've seen so many patients who have mental health issues like schizophrenia, PTSD at the VA, who have sleep trouble. And sleep medicine, by and large, has been under the under the discipline of pulmonary critical care medicine. So these patients are not getting much of the care. So we refer them to sleep centers. I mean, those pulmonologists, nothing against them, they're my colleagues, we work very well together, but they just take care of the sleep apnea, but they're not really very well versed, they don't know the details, they don't know how to work with these patients. So I got interested in sleep medicine. So much so that I'm very passionate about teaching sleep issues in mental health patients to mental health providers. So one of the efforts which Imran mentioned is actually a book which is now published next month. I think my bio was a year old, so this is going to be published. It's already available on Amazon right now. So this is a case book on sleep and comorbid psychiatric disorders. It's cases, about 23 cases, and most of the authors are from Mayo Clinic, from UT Southwestern, Northwest. So these are all professors and academicians who are experts in the field. So they've written chapters on different sleep disorders and how they're comorbid with a lot of mental health issues. Okay, so as mental health providers, you are the first people who treat these patients with trauma. And they are the ones who are going to tell you the first they have sleep problems. So it's very, very important for us to know how to help these patients, how to kind of recognize sleep disorders in these patients. Now, this presentation is going to help you understand, and I will provide an update on sleep disturbances PTSD patients. Also, what are the comorbid sleep disorders which we can see in this population. So let's look at what are the objectives for our presentation today. So we'll describe sleep architecture, this regular sleep architecture, and then sleep architectural changes in patients who have PTSD. We'll learn about 3 most common comorbid sleep disorders. Now, at the end, I'm hoping that you're going to be able to screen and diagnose patients and refer patients when appropriate. So this is how we're going to go. We're going to learn about what normal sleep architecture is, and most of you may already know what it is because you're experts in mental health, and you know that, but maybe we'll just revise it, and feel free to ask any questions if you have. So I want it to be more interactive. So if there's a question, please stop me and we can verify if there's anything. You'll learn about a case of a patient with severe PTSD and sleep issues, and you can see how sleep disorders can play into patients who have PTSD. Sleep architecture changes and what happens in patients who have PTSD, what kind of sleep disturbances, what kind of polysomnographic changes do these patients have. And then look at what are the common sleep disorders which are comorbid, and then look at treatment options. So let's start. So question for you. So what do you guys think? What is sleep? Is it a simple passive process? Is it an active process? Simple active process? Or all of the above? So who says A? We're looking at sleep. What is sleep? Is it a simple passive process? Your brain is sleeping, so not much going on? Okay. Who says it's an active complex process? Great. So sleep is a very active complex process. It's not all of the above, it is an active complex process. Now granted, there are times when we are sleeping and our brain is a bit passive, but there's a lot of activity going on. So let's look at sleep. No, we've in the last 5-6 years, we've found a lot of things. Now, what the picture I'm showing you right now is a picture of brain. And as you can see, just recently, this is about maybe 2013, it was found that there are different functions of sleep. So we still don't know exactly, it's difficult to pinpoint what's the function. Now, some people say that, yep, it's kind of a rejuvenating thing, you have to have it, the body and the mind, the body rebuilds, it's rebuilding certain things, the brain is resting, that's all true. But if you look at this picture, the right side, if you see here, these scientists in New York, they found that there is, just like lymphatic systems, we are all familiar with the lymphatic system in the body. So in the brain, they found that there's a lymphatic system, which means that there's some toxins which are produced within the brain as we are active throughout the day, and at night, these lymphatic tunnels get widened, just like when you have to clean the streets of New York, the cars are not parked there, so it's open up so you can clean it. Similarly, here, when it's first asleep, especially mice, these lymphatic systems open up and they get rid of the toxins. So one of the function of sleep we know now is that it gets rid of the toxins in the brain which have been accumulated over the last 24 hours. So looking at sleep now, so sleep is what? Non-REM and REM. These are 2 different types of sleep. So what is REM? REM stands for what? Rapid eye movement sleep. So as the name denotes, the eyes are rapidly moving during that part. So let me show you. So there are 2 types of sleep. Non-REM, brain is somewhat resting, body is somewhat resting, but when you are in REM, it's a very highly metabolic neurological state, meaning your brain is very active during REM sleep. It's almost like just when you are awake, but you're asleep, you're having a dream or something of that effect. So let me show you a typical sleep. What happens, again, I apologize, this slide is not very clear, I thought it should be, but what happens when you sleep, you go from being awake into non-REM stage 1, 2, 3, and then you go into REM sleep. So time is going in this direction. Remember, time is going in this direction, you fall asleep, you go into non-REM, or just call it N1 sleep. Go into N1 sleep, N2 sleep, you go into N3 sleep. Now N3 sleep is the one which is more, or we call it as deep sleep, or we call it delta sleep. So this is considered to be the one type of sleep where people are more, it's more restful sleep. So when people say REM is restful, well, it's not exactly true. REM is rapid eye movement sleep, and it's not necessarily restful sleep. When you get into non-REM 3, that's what we call as delta sleep, which is the brain waves are really, and I'm going to show you some of those brain waves. So a person goes from N1, N2, N3, goes into REM sleep, and the time is good. Then this is one sleep cycle. And then after a few minutes, they go back into N1, N2, N3, and another REM. So do you notice what's happening to the REM sleep as the time is going on? This is REM, so time is going, so is it getting bigger or less? More. So you're getting you're getting a lot more of REM sleep in the morning. So as the night goes on, you're getting a lot more REM sleep, and as the night goes on, you're getting less of the delta or the deep N3 sleep. So remember, that's why how many of you wake up and you're having a dream in the morning? It's because you're having a lot more REM sleep around that time. That's why. So here's the different types of brain waves, and Mark Ryder, remember, he does a lot of the EEGs and he knows a lot of that as well. If you look at the beta frequency, the alpha is when somebody is more relaxed, they have their eyes closed, they're about to fall asleep. This is theta. This is delta, which is the frequency is 1 to 2.5. This is the delta sleep which we get when we are in stage N3, which is supposedly more restful sleep. So looking back again, non-REM, brains are relaxed, body is relaxed to some extent, but a person has internal orientation, meaning they don't know what's going outside. So when you're sleeping in your non-REM sleep, you don't know what's going outside your body, so you have an internal orientation. When you are in REM sleep, now remember this point because it's going to come back again. REM sleep, highly active brain. Brain is highly active. Do you have external orientation or internal orientation in REM sleep? Internal orientation because you don't know what's going outside. You may be dreaming, but it's internal. And the bodies are paralyzed. Now I'm going to repeat, the bodies are paralyzed with the exception of a few muscles. Now I'm not saying the bodies are relaxed. The bodies are literally paralyzed. Except the muscles, the diaphragm muscles, the eye muscles, the penile muscles, and also some ear muscles. So the rest of the body, if you're in REM sleep, we do a reflex check on you, you're not going to show any reflex because your body is actually paralyzed. And that's why we do not act out our dreams. We are not punching and kicking and all that because our bodies are paralyzed. Otherwise, all of us would be punching and kicking in our dreams. Now, obviously, you know that. How many of you know REM behavior disorder? Familiar with RBD or REM behavior disorder? So we're going to learn about that. That's a disorder which was discovered by Carlos Shen. And this is something I'm passionate about because RBD is quite common, and sometimes it can mimic patients who have PTSD. Okay, so remember, REM sleep, brains are active, bodies are paralyzed, internal orientation. When you're awake, brain is activated, body is activated, you have an external orientation. So let's look at a case of a patient. Okay, so I'm going to present this case to you. This is a gentleman who came in. This is actually a real case. The picture is not real, of course, but the case is real. I saw this patient back, and I've seen several of these types of patients since I've been working at the VA. But this gentleman I saw back in the VA in Minneapolis several years ago. And the main complaint was he was referred to us by one of the psychiatric providers saying the patient is having some problems with nightmares, and the chief complaint was, I'm having nightmares on my back. That was his chief complaint. Okay? A little bit atypical. So this is a 63-year-old married Caucasian male, a Vietnam-era veteran who was a tunnel rat. And how many of you know what is a tunnel rat? Can somebody tell me what it is?
Yeah, happy to. It's a guy who went into the tunnels for us to look for ammunition caches.
Absolutely. Exactly. So,
small tunnels.
Yeah, so these folks were usually not very big in size. These were small soldiers who would be asked to go into tunnels to look at it. There's ammunition, there's stuff, there's bombs, stuff like that. So it's a pretty scary thing. You're in the tunnel and you're trying to look for it. There's not much light there. So he would wake up with nightmares, especially on his back. And he would say that he cannot go back to sleep. And his typical nightmares were that I'm in a tunnel, and he had PTSD. I'm in a tunnel and I can't breathe. The tunnel is falling and there's a lot of dust and all that, and I can't breathe. And he would wake up. But he remembered that he would only have these nightmares when he is on his back. Because that's an important point I want you to remember. Okay? Other problems he had, wife said that, yep, he wakes up gasping and snorting. He has dry mouth in the morning, has been snoring for many, many years, becomes very sleepy during the daytime, can fall asleep easily. Snoring is worse on his back, it's a typo, on his back. He's been prescribed several anti-hypnotic medications like Ambien and other medications. They help, but then still they don't help very much. Wakes up with a lot of nightmares. Can't go back to sleep. He still has PTSD type symptoms. Wife says that he still acts out his dreams. He's thrashing, he's kicking, and he's pushing, and wife doesn't want to sleep in the same room. Now, if you look at the medical history, he's got a typical medical history of a patient who's somewhat obese. So, high blood pressure, diabetes, coronary artery disease. He's quite heavy set. His BMI is quite high since he wasn't a very tall guy. And his neck circumference is 18 inches. So it's a pretty big neck. So let's have a bit of a discussion. Let's see, what do you think this guy, again, we're going to look at a couple of sleep disorders. What kind of sleep disorders this person might have. I'm going to get on the side here. So my question, and again, there's no right or wrong answer. What sleep disorders does this person possibly could have? So,
Sleep apnea.
Well, sleep apnea, absolutely. What else?
REM sleep disorder?
Yeah, he could have REM behavior sleep disorder because he's acting out his dream. I'm not saying he has it, but he could have RBD. Because what RBD is, people are acting out their dreams. So the mechanism where the muscles are supposed to be paralyzed is not working. What else?
I was going to say nightmare disorder, but you make a distinction with the REM, the RBD.
Sure. So nightmare disorder could be a possibility. But remember, nightmare disorder is going to be, again, he could have nightmare because he's having nightmares. But nightmare disorder, we diagnose somebody with nightmare disorder if they do not have PTSD. So they just have nightmares and they wake up and it's distressing and they can't go back to sleep. But if somebody has PTSD, nightmares are part of the PTSD syndrome. What else? Okay, so we identified 3 or 4. So we have obstructive sleep. But what about insomnia? So obviously he has insomnia. He's waking up, he can't go back to sleep. So he has comorbid insomnia as well. So this gentleman could have obstructive sleep apnea. He could have REM behavior disorder because he's acting out his dream. What about restless legs or periodic limb movements? Because people can kick. So he could have that. Obviously he has insomnia because he's having trouble staying asleep and he's waking up. And then he could have nightmare disorder if he doesn't doesn't fit the criteria for PTSD. So do you think this patient has PTSD? Again, I didn't give you the whole details, but well, he has history of PTSD, but it's well controlled. He still has some residual nightmares. Now, obviously, I didn't give you enough information to look at the criteria. Well, does he have nightmare disorder? Well, if he does have history of PTSD, then we may not be able to say he's got a nightmare disorder. Why is he having nightmares on his back? That's an important question. What?
Because when he was doing his tunnel and stuff, he spent a lot of time on his back, itching through the tunnel.
Well, I mean, when you're going into the tunnel, you don't go on your back.
No, but when you're in the tunnel, some of the guys would go
Sure.
in the back to move along.
Sure, yeah, it could be.
An Asian person, I don't know the medical, but I'm
Okay,
saying.
okay. Well, that could be very well. Let's see.
You mentioned something about his fear of it collapsing down on him, so maybe the pressure on his back makes it feel like the tunnel's collapsing down on him.
Okay.
Would his apnea be worse if he's on his back?
Absolutely.
Yes.
Absolutely.
Yes.
So when patients have obstructive sleep apnea, it's usually worse on their back. When they're sleeping on their back, their tongue is falling back and it's cutting off the area. So obstructive sleep apnea is always worse on their back. So much so that sometimes you just tell them to sleep on their side if they have positional sleep apnea. Now, here's what I want you to understand. So this is his oximetry. If you look at his oximetry, you're looking at the oxygen levels here. So look at this. His oxygen levels are fine, about 90, but then it correlates with REM cycle. You know, we have REM cycle. You saw that period where I showed you different sleep cycles that you have REM. The more REM at the end, so he's having a lot of those REMs in the here, and he's having a lot of these apneas where his oxygen levels are going down. Okay, now, so let's see what this patient can have: obstructive sleep apnea, insomnia, periodic limb movement, and REM behavior disorder. Now, one thing I want you to understand is that when we have dreams or when we are going through REM, do you usually remember your dreams when you go through your first REM cycle so you don't wake up from it? Do you remember that dream? No, you don't remember your dream. You usually remember the dream when you wake up from the last REM cycle. Make sense? So, women actually can remember better because they're smarter, but men don't. The study is showing that men do not remember their first REM dream or something. The last one, obviously, you wake up. So the brain needs to wake up from a dream to be able to remember that. So you wake up, you register it, and you think and you remember it. If you don't wake up from it, you're not going to remember it. So this is exactly what happens with patients who have PTSD. In my book, there's a chapter which actually one of my colleagues has written, a similar case. Because when people have sleep apnea, they're sleeping on their back or even otherwise, they're going to go into REM sleep. If they have PTSD, they're going to have a nightmare. And the sleep apnea is going to wake them up from that. It's going to get them out. They're going to wake up or have an arousal. Are they going to remember it more or they're not going to remember it? So they're going to remember the nightmares more. A patient with PTSD who's going to remember their nightmares a lot more than the one who does not remember their nightmares, who's going to have worse PTSD? The ones who remember it. So there's a gentleman by the name of Faris Naveed. He's a psychologist from Israel, and he's one of the founders of doing sleep studies, PTSD, patients with PTSD. He's done a lot of work on Holocaust survivors as well. So I know him, I've talked to him on the phone several times. And he has done several studies looking at Holocaust survivors, in which looked at one group which is control. They went through the trauma. The other group went through the trauma, but one group is having a lot of adjustment problems, a lot of PTSD. The other group does not have it. Meaning they went through the same trauma, they're well adjusted, they're doing fine, no depression, PTSD. And they looked at their dreaming and asked them about dreaming. And one of the things was that the ones who are well adjusted, they remember their dreams, but those are pleasant. They don't remember all of their dreams. Whereas patients who have PTSD remember their dreams a lot. They wake up from their nightmares, so they have a lot more subjective sense that their sleep is worse and that they're remembering those nightmares. So when we look at PTSD, for example, there's only two symptoms pertaining to sleep. If you look at nightmares is one, and difficulty falling asleep and staying asleep. But sleep, there's so many other disorders like obstructive sleep apnea which makes things worse. Okay. So these are some of the things which, when I work at the VA, so what I can say about PTSD, I dream I'm fighting back, my wife, so they actually think that they're acting out their dreams, but in most cases they're not. They don't necessarily have REM behavior disorder. So veterans or patients who say that I'm fighting in my dream, it's actually it's a different phenomenon. It's not necessarily REM behavior disorder. Now they could have RBD as well, but in most cases they do not. So nightmare-associated activity during night is not considered as a parasomnia at this point. Okay. So let's see what happens to sleep architecture in patients with PTSD and effects of poor sleep on PTSD as well. So you see veterans. Okay, careful. Yep.
Thank you.
Okay, so look at sleep is really, really bad in veterans who come back and they have really horrible conditions in which they sleep. So obviously they're going to have difficulty, they get conditioned. Sleep is a conditioned phenomenon as well. So sleep is one of the most frequently reported symptoms after trauma exposure. You look at combat POWs, natural disaster victims, terrorist bombings. So a lot of it, sleep gets affected really quickly. If you look at some of the Pittsburgh sleep quality index scores, you look at it, all these trauma-related can cause worsening of Pittsburgh sleep quality index. So post-trauma sleep problems, what can people have once they've gone through traumatic event, whatever the trauma is? They can have nightmares, insomnia, excessive daytime sleepiness. Within 1 month of post-trauma, predict PTSD symptoms. But there was a study in Minneapolis, one of my colleagues in the VA Minneapolis, they did a ring study. I don't know if you're familiar with that or not, but that was a study which was not necessarily related to sleep as such, but what they did was they did a number of questionnaires on, I think it was Minnesota National Guard, and they were going to be deployed. So before they were deployed to Iraq, like I think in thousands, they came to the VA and they had a lot of questionnaires, psychological tests done, MMPIs done, a lot of questionnaires pertaining to depression, anxiety done, and a lot of them, and obviously these questionnaires have sleep-related questions in them as well. So it was a prospective study, so this is pre-deployment, they go to the war zone, and after a year or so they come back, and the same veterans, same soldiers go through the same questionnaires again. So what they found was the ones who had somewhat of poor sleep in the questionnaires or in the assessments before had very high likelihood of developing post-traumatic stress disorder. So this was a prospective study which was very good and it was published by one of my colleagues. So let's look at, I want to talk to you about this trauma-associated sleep disorder, a parasomnia induced by trauma. Now, remember I said so far it's not considered as a parasomnia. So do we know what a parasomnia is? No. So parasomnia are sleep disorders, which means that behavioral activities occurring within sleep duration. So for example, REM behavior disorder is a parasomnia where it's happening in sleep which is not desired. Another example of parasomnia which you see a lot of times is sleepwalking. So how many of you have seen patients with sleepwalking? So sleepwalking is a parasomnia. Nightmare disorder is a parasomnia. So PTSD related sleep problems are not so far considered as parasomnia yet. They may be. So this is a paper by Vincent Mislevic, who's a colonel at San Antonio. And actually he's written a chapter in my book on the same topic. So he's come up with this idea that patients or veterans or soldiers who go through this traumatic event, they come up with some symptoms which can be like a syndrome and can be called as trauma-associated sleep disorder. Now, what is he proposing? He's proposing that this is a syndrome, and he's calling this is trauma-associated sleep disorder, which is a unique parasomnia, and you all know what a parasomnia is, incited by extreme trauma and sleep deprivation or disturbance that negatively impacts the sleep quality of the patient and the bed partner. So this is what he's proposing. While disruptive nocturnal behaviors are frequently reported in patients with trauma-associated sleep disorder, they are rarely captured during polysomnia. And we know that because one of my co-editors, Tom Horowitz in Minneapolis, has done several studies back in the 90s looking at PTSD patients and doing polysomnographic studies, sleep studies, to see whether there's any major changes in their sleep. And they didn't find much, even though we know that there are some changes, and we'll learn it in a minute. Hyperarousal during sleep underlies the clinical manifestation of trauma-associated sleep disorder. So, you may see that coming up in the next few years, that there's going to be a trauma-associated sleep disorder. So far it's not. It's in the making. So let's look at what are the polysomnographic findings. If we do, there's so many studies done looking at patients with PTSD saying what kind of sleep trouble do they have. Now we all know clinically they can't fall asleep, they cannot stay asleep, they have nightmares, but what does it do to the sleep stages? Does it make any changes? Does it increase REM sleep? Does it decrease REM sleep? Does it increase the slow wave sleep or decrease it? So what do you guys think? Let's make a guess. Do you think the REM sleep is increased in these patients or decreased?
Increased.
Increased, absolutely. Very good. What about in depression, major depressive disorder, is REM sleep decreased or increased?
Increased.
Increased.
Oh.
Increased. In depression as well, and in PTSD, REM sleep, there's increased REM sleep. There's increased REM sleep. Yes?
How come a lot of depressed patients don't report dreaming until they kind of usually start on antidepressant?
Well, that's a very good question. And again, it should be the other way around, meaning that when they get put on antidepressants, and then most of the select SSRIs, these drugs inhibit REM sleep. So it's possible that once they get put on these antidepressant medications, they have low REM, they don't have much of REM sleep. But that's an important thing. I don't know.
But they start talking about dreaming more. How dreams happen.
Well, I mean, it's possible that their cognition is better. I mean, they're doing better because remember, we need certain neurotransmitters. For example, norepinephrine is to register when they wake up to remember. So some of these antidepressants can have an effect on that. So that could be a possibility, but I'm not sure. Actually, it's the other way around because when they're depressed, they're going to have a lot more dreams. They may not remember it because they're having some, they're maybe having some pseudo-dementia or something to that effect. But on antidepressants, they are doing better so they can remember it. But it should be the other way around, because once they get put on antidepressants, with the exception of Wellbutrin, the others are going to decrease the REM amount. So REM sleep is increased. So let's look at the slide. The findings were mixed in the beginning. We didn't know what happens, but some studies did not find any major changes in PTSD. However, there is modest reductions in sleep time and sleep efficiency, meaning that these patients, they don't sleep as much. Their sleep efficiency, meaning that the time they are actually sleeping divided by the time they're in bed, is less. Then some studies, and most of the studies are finding this, reduced slow wave sleep. So they don't have the delta sleep. So the restful sleep, they don't have much of the delta sleep. They have greater REM density and more stage 1. Okay. Now the delta sleep, stage, do we know what is REM density? So REM density is, REM stands for what? Rapid eye movement sleep. So density means how many times the eye movements are going on. So these patients have increased eye movements, a lot more eye movements in REM sleep as compared to the ones who don't have PTSD. We don't know what the reason for that is, but that's a typical finding. It's a finding in patients who have depression, also patients who have schizophrenia. Okay. So let's look at the behavioral effects of sleep fragmentation in PTSD, because we know that. The one thing I want to say is something else. What do you think of increased arousal threshold? So this is a study that we see by Paris Levy. You see 1991 Paris Levy. Increased arousal threshold, which is contrary to our common sense, because you would think about that somebody's got PTSD and you touch them, they're going to wake up pretty quickly. Their arousal threshold is low. But Paris Levy found that PTSD patients who have, it is difficult to wake them from their deep sleep. It's common sense would say, yeah, you touch them, they'll wake up. But if they're in their delta sleep, it's difficult to wake them up as compared to controls. And the explanation he gives is that a lot of times the patients are like they're dreaming, or even if they're in delta sleep, they're not dreaming. They are kind of like inside their mind. They are really focused there, and it's a protective mechanism. But sometimes it works, sometimes it does not. Okay. So looking at behavioral effects of sleep fragmentation. So people have anxiety, depression. Now this is Caraco, who's from New Mexico. He's actually an internist, and he's done a lot of work on nightmare therapy. I think image rehearsal therapy. He's got a lot of work on that. So somebody who's got anxiety, depression, PTSD type symptoms, they develop problems with poor sleep. They have trouble with daytime fatigue, low energy, so that causes them to have psychosocial problems, isolation. So it's kind of a cycle, and he called it sleep misery cycle. This is Caraco's work. Now what about mental effects of sleep disturbances? Somebody's sleep deprived, they can have all of these symptoms. Now you can see dysregulation of response inhibition, avoidance of effortful tasks, cognitive problems, emotional dysregulation. So what do you think? If somebody is sleep deprived and they have all these type of symptoms, how close they are to PTSD? How many of our PTSD patients have these symptoms? All of us are PTSD. So if somebody is sleep deprived and they have PTSD, it's going to worsen their PTSD symptoms, because sleep deprivation causes all these three things. Okay. So we know that sleep problems may exacerbate mental illness. What else can sleep problems do? So this is some studies done. This is a little bit older study, but looking at predictors of suicide in adults. So look at short term, within 1 year, global insomnia is there. Obviously long-term suicide ideation. Treatment of psychiatric symptoms do not necessarily alleviate sleep disorder. So this is an important thing. The field has gone a bit different direction. Previously, I'll say 10 years ago, people used to think, well, somebody's got depression, PTSD, and they have sleep problems. That's okay, because we're going to treat the depression, PTSD, and the sleep problems are going to get better. Is that the case? Not really. So the recommendations are that if you're treating PTSD and you're treating major depressive disorder, and they have a sleep disorder, no matter what it is, insomnia, sleep apnea, you've got to treat that separately and simultaneously. So there's studies looking at antidepressant effect, CBT, cognitive behavioral therapy for depression, and if the arm in which you're treating the insomnia is going to get better more quickly, and they're not going to have relapse. So because insomnia and sleep disturbances are most common residual symptoms of PTSD and of major depressive disorder. Okay, so let's come back and talk about learn about comorbid disorders. And don't think we have too much time, so I have to quick up a little bit. So here's, we know that these are the three main disorders: insomnia, nightmares, OSA. Now, RLS and periodic limb movement, we didn't touch much on that. Are you familiar with what restless legs is? What is that? Can anybody tell me? What is that?
Next movement,
Okay.
when you're resting or sleeping.
Yeah.
Is it leg kicking?
Well, leg kicking is more periodic limb movement disorder. But there's a distinction between the
It's
two.
involuntary.
What is that?
Involuntary.
Involuntary. However, there's a bit of a difference between RLS and periodic limb movement disorder. If somebody has restless leg symptoms, which are basically four main symptoms, like they have a discomfort in their legs, like an urge to move, it could be pain, urge to move, tingling sensations, things of that nature. It's usually worse in the evenings at night. It's usually worse at rest, like long car rides. It gets better if they get up and walk around or massage. So these are the four criteria for restless legs. Now if they have subjective symptoms, they're going to have restless legs. They cannot have periodic limb movements, even though they kick 100 times in 1 hour. It doesn't matter. But if they have subjective symptoms and they have restless legs, and on a sleep study we see that they're kicking all over the place, they're going to still have restless legs. So periodic limb movement disorder is very uncommon, because most of the people who have periodic limb movements during the sleep study or at night, they have symptoms of RLS. So for practical purposes, majority of our patients have RLS. They may have periodic limb movements during sleep, but it doesn't mean they have periodic limb movement disorder. Okay, so this is an important thing which I want to emphasize, and you all know that. How many of you have patients who have insomnia and it's very difficult to treat? Yeah, and they get put on medications. How many of you can do some cognitive behavioral therapy for insomnia? So that is cool. That is really cool, because this is something which is really needed. Okay. So it is recommended that patients be treated for insomnia and PTSD issues simultaneously. So we all know that. I'm not going to spend much time. This is insomnia disorder in DSM-5 back 5 years ago. They changed. Remember, it used to be acute, it used to be chronic, it used to be secondary insomnia. So the DSM-5, as well as international classifications of sleep disorders, 3 has gotten away from primary versus secondary. So there's a marked departure from ICD-2, which is International Classifications of Sleep Disorders, and DSM-4. There's no distinction between acute, chronic, no distinction between primary and secondary. Why do you think that's the case? Because they don't want you to think of secondary insomnia. They don't want you to think, okay, somebody's depressed, they have secondary insomnia. Because we want to think of insomnia and sleep trouble as comorbid. So it's going to be comorbid insomnia, so you want to treat it simultaneously. You don't want to just treat depression, PTSD, you want to treat insomnia simultaneously. So to get away from that kind of thinking, they changed. And in most cases, insomnia is chronic, so they got away from that as well. Now this is, so talking about insomnia, this is a study which I was part of, this is a couple of years ago now, but this was a pharmacological treatment of insomnia. So this was published in Annals of Internal Medicine, and I was the consultant to this group, which is Timothy Well, who's a well-renowned statistician, and he's an internal medicine person. He works for ARC, which is I forgot the name, but he works for the University of Minnesota, but he does a lot of meta-analysis. Any questions which come up, he gets grants to answer those questions. So this was the question which we answered, and we did a big meta-analysis from the years 2006 to 2016. 10 years of studies, looked at studies on insomnia, both for pharmacological treatments and for non-pharmacological treatments as well. Okay. And so this became the part of the guidelines. So this work was part of, sponsored by American College of Physicians clinical guideline, which was published in 2016. So if you look at it, the recommendations which came out of the meta-analysis, just look at this. American College of Physicians recommends that all adult patients receive cognitive behavioral therapy for insomnia as the initial treatment for chronic insomnia disorder. The strong recommendation, strong evidence, the grade of evidence was pretty strong. But how much, like patients come to psychiatrists, they get put on medication. So how many of you know that patients get cognitive behavioral therapy as a first-line treatment? Not much. Okay? As far as recommendation 2 is, it recommends that clinicians use a shared decision-making approach, including a discussion of the benefits, harms, and costs of short-term use of medications to decide whether to add a pharmacological therapy in adults with chronic insomnia disorder, in whom CBTI alone was unsuccessful. So they're not even recommending we use medications. Again, after this, 2017, American Academy of Sleep Medicine came up with guidelines. I wasn't part of that. There were some people who were really big, and they came up with the same recommendation, nothing different. So here's what the recommendation is. You really go with sleep hygiene. You can start with it, but there's not much of evidence that sleep hygiene alone is going to help these patients. CBTI for insomnia is certainly the main treatment. And if it doesn't work, we can consider other medications. So there's plenty of medications we can use. We all know that there are not too many medications approved for more than 30 days. Some of these hypnotics to reduce slow wave sleep and REM sleep, especially medications like benzos. Medications like Ambien or Zolpidem may not have much of an effect. Sometimes they can exacerbate, benzos can exacerbate sleep apnea. They can cause daytime sleepiness. So behavioral therapy has equal effects in short term, superior in long term. So we know that cognitive behavioral therapy is better in long term because patients are not going to have much of side effects. Now, you're all familiar with it, but I thought I'll just quickly go over some of this. So CBTI is an excellent candidate for sleep in depression and PTSD patients. So cognitive behavioral therapy is a state of art for insomnia, depression, and PTSD. CBT is well tolerated, acceptable. Unfortunately, there are not too many therapists that people know about it, but they're not actually formally doing it. Like 6 to 8 sessions with having them do the sleep diaries, having them go through really different strategies like sleep restriction and stuff like that. Okay. So these are some of the elements of CBTI. As you all know, stimulus control. How many of you know what stimulus control is? So stimulus control, how many of you know that, we all know what Pavlov dogs experiments were? So people who get insomnia, most of the time, sometimes we call it psychophysiological insomnia or conditioned insomnia, which means that their minds are kind of conditioned that they're in their bedroom and they can't fall asleep. Almost the same thing as Pavlov's dogs experiments. So the Pavlov had his dogs, the dogs were conditioned that every time the bell would ring, they would get food. So they got conditioned, bell, food, and they started salivating. You remember that? So in patients who have insomnia, obviously it could be triggered by any trauma, but then what happens is that they are in the bedroom, and the bedroom is the bell now, because every time they're in the bedroom, they can't fall asleep and they've had stress. But when the stress goes away, they go into the bedroom. Bedroom is the bell, and they're not being able to fall asleep, and their mind racing is the salivation. So it's a conditioned response. So stimulus control therapy is that we're going to control that stimulus. We're going to ask them not to be in their bedroom at all, if possible, only for sleeping or lovemaking. And if they can't sleep, they don't need to be in the bedroom. I tell my patients, that when you are in your bed and because most patients, oh no, I'm not in my bedroom at all, doc. I'm just in there, I'm just trying hard to sleep, I'm just laying there, I don't do anything else. So I ask them, what about when you're trying hard to fall asleep? Say, yeah, I'm trying to fall asleep because I gotta get some sleep. But what about, so I ask them, okay, well you're trying to fall asleep, is it a very peaceful state of mind when you're trying hard and you're not able to fall asleep, and you're tossing and turning, and every one of them says, no, not at all, I am stressed out. And I tell them, this is what you're conditioning your mind to be when you go into your bedroom. So you do not want to be in a stressful mind when you are in your bedroom. You want to train and condition your mind that you are in your bedroom and you are doing what? And all of them say, yes, sleep. So they get the point that, so we do not want them to be in their bed tossing and turning, looking at the clock. Even if they don't spend another minute in the bed, but if they are trying hard to fall asleep, they're not going to sleep very well. So here's sleep restriction. As the name says, we want to restrict their sleep. We don't want them to, if somebody's having trouble sleeping, we can restrict their sleep time. Say, okay, well, if you are in bed 8 to 10 hours and you're only sleeping 5-6 hours, just be in your bed for 6 hours. Again, I'm simplifying it. It's not as simple as that. cognitive restructuring. Most of my patients who are having trouble with sleep, they are scared of insomnia. And one of our mentors at Mayo, Peter Hardy, who is the author of the book No More Sleepless Nights, he used to say, you have to train your patients not to be scared of insomnia, because most patients are scared because they dread the night, because as the night comes, they know they are anticipating insomnia, so they are scared of it. So we have to get that out. The cognitive portion of the CBTI helps with that. And again, there's education and relaxation. Some of the other things, obviously, we limit caffeine, limit alcohol. By the way, what does alcohol do to sleep? What does it do when you drink it? Like when you drink 2 or 3 drinks, what does it do to sleep?
Well, you get to sleep like higher,
Yes.
anxiety comes back.
Absolutely. So alcohol helps with sleep in the beginning. Actually, alcohol increases slow wave sleep, meaning it puts people to deep sleep. So why don't we use it as a hypnotic? We don't use it as a hypnotic because within the next 2-3 hours, when the alcohol is getting out of the system, it really makes the sleep extremely fragmented. It adds more REM rebound. People can have nightmares. So alcohol is not a good hypnotic. Okay.
But what about,
Please.
what about those that say that the doctor said they could take maybe a glass of wine?
Well, I mean, a glass of wine, it should not be just before bedtime. If it's for dinner, it's okay. But by the time you're going to sleep, if you have dinner at 6 o'clock or so, 7 or 7, but not before bedtime, it's not a good idea. Okay? Because it's going to disrupt your sleep. Okay, so what do we do in stimulus control? So bedroom and wakefulness becomes associated with vulnerability if patients are having insomnia. To change that association, we tell them go to bed only when sleepy. If not sleepy, within 20 minutes, get out of bed and do not return to bed unless sleepy. Repeat this pattern consistently. Get up at the same time each morning. Don't oversleep. Don't take too many big naps because that will mess your sleep up. That is only used for sleeping and intimacy. So this is stimulus control. Okay, this is a saying, many things such as loving, going to sleep, or behaving unaffectedly are done worst when we try hardest with them. So sleep is one of them. You cannot force yourself to fall asleep. So we looked at the insomnia, to summarize that. This frequent and significant clinical concern in patients who have PTSD. Insomnia may precede an excess of great psychiatric symptoms. Warrant separate clinical attention, so we want to treat that separately. CBTI is effective in improving sleep and reducing psychiatric symptoms and tolerated well. Now, nightmares, we're going to skip nightmares, and there are image rehearsal therapies which could be used. Some of the medications which we have used is prazosin, which is a blood pressure medication, and actually it is helpful, but the latest evidence is not very supportive of that. Okay, so I'm going to quickly move. I'm going to take another 2 minutes and wrap it up. So we know that, let's move on to sleep apnea. This was a study done by Amir Sharifani and Max Hershkovich. Max Hershkovich is a big name. He's retired now. And they looked at a lot of veterans in the Houston VA system and found that significantly higher rates of psychiatric disorders in patients who were sick. 22% in depression, 17% in anxiety disorders, with 12% in PTSD. So what is obstructive sleep apnea? You all know that. I'm going to quickly go over that. So this is a sagittal section, like the face is cut like that. You can see the nose, the tongue, the chin. This is the throat. So when a person breathes, the air is going through the nose or in the mouth, going behind the tongue into the lungs. Patients who have obstructive sleep apnea, especially on their back, look at the tongue is falling back because of the gravity. So that is obstructed. So that causes OSA. So we call this as a sleep apnea cycle. So somebody has inadequate anatomy, they have oral cavity exam which is crowded. When they fall asleep, when they're awake, they don't have any apneas, but they fall asleep, the tone of their muscles go down. When that happens, as soon as they fall asleep, their airway collapses, and when their airway collapses, they have decreased oxygen, their body wants to breathe, they have increased in their respiratory effort, they may have an arousal. So they wake up and they start having, these events. So this can keep on going and on. But look at that, the sleep fragmentation, because they're waking up and they sometimes don't even know that, is going to cause neurocognitive problems. The sympathetic activity is going to cause cardiovascular problems. Now we know that intermittent hypoxemia, meaning that oxygen levels going down, going up, going down, is more of a more damaging to the cells of the blood vessels than consistent hypoxemia. Now these are the devices which we use. We do formal sleep studies, but at my lab, actually my clinic, I use this device, which is technology actually built by Dr. Paris Levy himself from Israel. So this is a technology from Israel. This is a simple test approved by Medicare. All it's recording is your oxygen levels and your peripheral arterial tone, because based on that, it can tell us whether somebody's stopping breathing or not. These are some of the other devices, but this is I like because it's very easy. You don't have to put something on your nose and your face. You're not even recording the airflow. So different treatment options. We know about CPAP. You're all familiar with CPAP. Actually, there are several case reports that patients with PTSD, if they have nightmares, you treat it with a CPAP, they do better. Why is that? Because they are still having the nightmares, but they're not waking up from those nightmares. So the nightmares are there most likely, but they are not waking up and remembering them. Now, oral appliances, are you familiar with oral appliances or dental appliances? So these are devices which people put in their mouth and pulls the tongue forward. Okay, so just a quick slide. Trauma exposure can cause PTSD symptoms, can cause insomnia, nightmares. There's more sleep fragmentation. When there's more sleep fragmentation, the upper airway is more collapsible. When somebody's waking up from falling asleep, it's more collapsible. As a result, they can have more sleep apnea. So I'm going to conclude here by saying sleep disturbances are common and are core symptoms of post-traumatic and trauma-related sleep disorders. Comorbid sleep disorders worsen PTSD outcomes. Patients with PTSD should be screened for OSA, insomnia, RLS, and RBD. Timely treatment of sleep disorders could prevent worsening of PTSD. And here I'm going to stop and thank you so much. You've been a wonderful audience.
We still have a few more minutes if you want to open up for...
Yeah, any questions?